This is about Mental Health Act in India. What is its impacts on health insurance industry? A research study by two young persons are going to make a presentation to you. One is Mr. Sabdar, other is John Buckle. Kindly come, occupy the seats. Okay, that's fine. Yeah. I will just briefly introduce the speakers to you. And I will give a time of around 20 to 25 minutes for their presentation together. And later on, we can have questions on that topic. The speaker is Sabdar, is a principal of Milliman's India GA practice and managing director of the Middle East practice. He has more than 20 years of insurance and reinsurance experience and has worked with clients in Asia and the Middle East. He has experience working on product design, pricing, valuation, mergers and acquisitions, risk management, business planning, and strategic consulting services. He serves as a panel actuary in India also, and is also the appointed actuary for a number of companies in the Middle East. He also advises leading financial and health regulators in the region. And the other speaker is John Buckle. Of course, same topic only. She is a principal and managing consultant for Milliman's health practice in London. She has experience in health markets from the US, Europe, to Asia and the Middle East. She works on traditional actual work such as pricing, capital modeling and reserving, but also has significant experience in managed care analytics and advise her clients on calculation methods for assessing the value of health interventions. She has significant experience in both the public and private health sector. In fact, I vividly remember, apart from this Mental Health Act, there is a Disabilities Act also in this country, which defines what is disability. In fact, insurance can be provided to these disabled persons also. And some of the insurers have some products to address the disabled persons also in this country. So I would request the speakers to go ahead, Mr. Jaffer, and let us understand this mental health insurance. And I think it is going to give good opportunity for health insurers. And also you are going to do, should say, good work to the society, beneficial to the society. Thank you.
Thank you very much. Ladies and gentlemen, I know this is the penultimate session of the day, so there are few people here, but hopefully we'll have a focused discussion. Just to introduce the subject in the context of the Mental Health Care Act of 2017 in India and the ramifications of that in the industry. It's important to understand that mental health care is very topical. The World Health Organization, in a landmark report in 2001, gave a global attention to this subject because there is a social stigma when we talk about mental health. It's a question of physical health, where insurance takes care of that component. But when we talk about mental health, there is always a socio-cultural stigma attached to what it means, what it entails, and whether one should go to psychiatrists or for treatment for such conditions. So the World Health Organization put together a task force in 2001 that led to an action plan from 2013 to 20, where they ensure that certain fundamental objectives are fulfilled as far as the universal right of every human being is concerned, and that includes mental health care. So the World Health Organization put together a proposition with 4 objectives. Number 1 was to strengthen leadership and governance as far as mental health care is concerned globally. Number two is to provide a comprehensive, integrated approach to mental health and the social care that is required within community structures. And number three was to implement strategies for the promotion and the prevention in mental health. And last but not least was to strengthen the information systems and the research and the development around this issue because there is no data as such. So it is with this spirit in mind that the Government of India, the Ministry of Health and Family Welfare put together a research which they published in 2016, the National Mental Health Survey of India. This was a survey carried out under the Ministry of Health across 12 different states in India. It is a comprehensive study available on the internet. It is a qualitative and a quantitative study where there was a task force that went out in 12 different states, collected data, spoke to the people on the ground, understood what mental health care is, talked to those who are affected by this. And the statistics that emerged as a result of this particular study were quite revealing in that almost 150 million Indians need some form of support in this area. Less than 30 million are actually seeking cure when it comes to mental health. And less than 10% of those are effectively getting the treatment that they deserve. And a lot of this is attributed to social stigma that the community should not know about it, or we don't know who to go out and talk to. And there were anecdotal evidences within this report that suggest that people didn't even know that they could go for treatment or for psychiatric support, or if they were addicted to drugs or alcohol and so on and so forth. So this study was quite profound and revealing that actually led to the Mental Health Care Act of 2017. So what I would like to do together with Joanne is to literally go through the various components, the key features of the Mental Health Care Act, the IRDA circular as a result of that, the mental illness, to understand what mental illness is. You know, as we were talking this morning about health insurance in itself being nascent in the maturity of our proposition in India, motor insurance and other lines are sort of advancing. This is where we are as far as health insurance is concerned, and particularly when it comes to mental health. So understanding and appreciating what mental health is and how would that impact us in light of this act is critical. So to understand the different components and different types of mental illnesses, what is included within the scope of the Insurance Act and what is excluded. And then we'll talk about some of the prevalences that we see in India. The challenges as far as the supply side is concerned, significant challenges. And thereafter, when we have sort of covered the Indian landscape, Joanne is going to talk about some of the international market practices as far as mental health is concerned. And last but not least, Milliman carried out a survey after the act last year, where we asked a series of questions to the industry as far as the Mental Health Care Act is concerned and the impact on the insurance industry. So we'll try and share some of those results and put some considerations as food for thought. As I said, this is very preliminary, and it is important that we are on a journey as we try to understand and dissect what mental health care is all about. So as far as the act itself is concerned, the act is to provide for mental health care and services for persons with mental illness, to protect, not only to protect, look at the wordings, to promote and to fulfill the rights of such persons during delivery of mental health care and services, and for matters connected therein or incidental thereto. So this act is profound, and there was a previous act in 1987. This act, in effect, abrogates or extends the scope of what the mental healthcare requirements are going forward. So effectively, this is a right of every individual in the country, that not only are you to be provided with the physical health care, the mental component is equally important. It attempts to protect the right of the mentally ill and enable citizens to decide on the method of treatment. So it's giving the choice for the method of treatment as well. And as a result of this act, IRDA also issued a circular on the 16th of August directing insurance companies offering health insurance to cover treatment for mental illnesses. So this is where the debate is, what will be the potential impact on the insurance policies, health insurance policies going forward, and because it has been excluded. It was an exclusion, and now it can no more be an exclusion as far as the act is concerned. So let's look at a few key features of the act itself. The rights of people with mental illness. The right to advance directive. This is where the preferred way of care is chosen. And not only that, the right of a person who is suffering from mental illness is that he can or she can nominate somebody to support him or her in the process. The number two is the right to accessibility both in public and private services. And number three is the right to confidentiality. The treatment that is given has to be absolutely confidential at every stage, at every phase of the treatment. As far as insurance provision is concerned, yes, it explicitly states that like physical insurance is provided, mental should also be provided. As far as the supply provision is concerned, the integration of at all levels of healthcare when it comes to public healthcare, primary, secondary, and tertiary. Bringing in professionals, and you will see the challenges as far as the supply side is concerned later on in terms of the number of people who are available to support those who are suffering from mental illness. The establishment of central and state mental health authorities throughout the country. And last but not least, the Mental Health Review Commission and Health Review Boards, who are supposed to assess and evaluate the effectiveness of this act going forward. As far as admissions, discharge, and treatments are concerned, admissions as independent patient in mental health establishments, it is limited to 30 days. If it goes beyond 30 days, then you need referrals from at least 2 independent psychiatrists out there. And the provision does not separate women and children below the age of 3 unless approved by the authority. As far as public awareness is concerned, wide publicity through the public media, television, and other channels to go out and educate the people that there is that availability or they have the right of getting the treatment in the country. And last but not least is strictness amongst especially on the professionals out there in ensuring that any unregistered establishment of health professionals are liable for a penalty. So you need to be registered and professional in this area of expertise. Now, the key question is, what is mental health? What is included? And what is excluded as far as the current health insurance policies are concerned? Now, as I mentioned to you that, this is very much at a nascent stage and the level of maturity is very early on, and we're trying to understand and appreciate the scope of mental illness. There's a pretty wide scope. I mean, if you look at the definition as per the Act, mental illness is defined as a substantial disorder of thinking, mood, perception, orientation, or memory that grossly impairs judgment, behavior, capacity to recognize, reality, or ability to meet the ordinary demands of life, mental conditions associated with the abuse of alcohol and drugs, but does not include mental retardation, which is a condition of arrested or incomplete development of the mind of a person, especially characterized by subnormality of intelligence. So you can see the scope is pretty comprehensive. And when you look at the landscape in itself, the numbers are quite scary in the sense that there is a significant population out there that requires the treatment. According to a WHO report, and there are so many numbers floating around, According to WHO report, 7.5% of Indians suffer from major or minor mental disorders requiring expert intervention. According to the report that was presented in this study through the ministry, you find the numbers are even more. But more importantly, there are fewer people who have access to professional treatment or professional support when it comes to mental. So it's a pretty comprehensive area to try and understand and appreciate the different components. And that's why to be able to dissect this, even as an actuary, I need to work with the clinician and try to understand what are the international classification of diseases as far as mental health is concerned, and how do I classify them into different components within the inpatient or within the outpatient spectrum to understand what is the scope and what is the potential price out there. So broadly speaking, when it comes to this report that was issued by the ministry in 2016, and these numbers come directly from the report, they are weighted prevalence rates across the board. Some of it is excluded, but just to put it in perspective here, you can see over here that you have the common mental disorders on the left-hand side with SUDs. SUDs is referring to substance use disorder. Yeah. And on the right-hand side is the SMD, which is the severe mental disorder that requires inpatient support. And this is where, you probably can broadly define as what is on the right-hand side is inpatient and the left-hand side is outpatient. But having said that, there is some ambiguity around what is covered and what is not covered under the Act, certainly as far as insurance industry is concerned. But what's revealing in this is that, the current prevalence is pretty high. And when you look at the split into the severe components, the severe medical disorder, it's a smaller component of the overall proposition. Life expectancy is expected to be a lot lower as far as that is concerned. But if you look at the left-hand side, and this excludes, by the way, tobacco. When you bring in tobacco, the numbers are literally shoot up. So the prevalence varies according to the psychological and social atmosphere. We'll look at some numbers. The prevalence peaks between the age of 40 and 49, and the common mental disorders are identified between different genders and different components of that. And then, interestingly, the urban metro has the highest prevalence rates out there. So I think the point here now is to try and understand some fundamental features within that, but just look at the numbers in the report itself. And you can see that as far as the numbers are concerned, the prevalence is highest within the middle age group. By gender, it's higher amongst the male. As far as marital status is concerned, it's probably higher amongst the widows and the divorced. Again, implicit challenges as far as depression and other components are concerned when it comes to the challenges that an individual faces in that segment. The prevalence by residence, the urban metro, interestingly, has the highest. The prevalence by education is primarily around those who have had primary education. And as far as the income quintile is concerned, it is at the lowest level. So you can see even from a socio-economic perspective, it is moving more towards the lower end of the spectrum. But having said that, the urban metro component is critical. This is just providing some more details within the comprehensive study that was done by the Ministry of Health and Welfare. So for example, when I look at the psychoactive substance use disorder, which is at 22.44, and you look at the graph at the bottom right-hand side, you can see almost 20.89. The bulk of it is coming from tobacco use disorder. When I look at the mood disorders, and by the way, those are the ICD codings, F30, F39. If you look at the mood disorders, you look at the right-hand side upper graph, you can see that the majority of that is depressive disorders. So there's a whole spectrum you can see across the board, and there is so much to understand and look into when it comes to understanding mental health and the coverage that we provide. Now, as far as the supply side is concerned, because it's important to understand that you have the demand component, you look at the prevalence rates, you say, okay, it's 10%, let's do some back of envelope numbers. The severe cases are almost 1%, the rest is 9%. We try and understand the numbers, but the critical part really is the supply side. What facilities are out there to support those who really need that attention that the Act is providing? So according to WHO and according to the report as well, you can see there's a whole spectrum of recommendations around where support should be provided, from the village level all the way to the community care. All these different forms of support are required depending on the type of mental care that you require. But what's interesting is this, that the level of the supply side is very, very challenging. We are talking of just 3.5, almost close to 4,000 psychiatrists in the entire country versus the need to have 11,500 to meet the current needs out there based on the prevalence rates that we see. And in all, if you add up all the professionals out there effectively, you find that there is a huge gap between the need and the availability. You're talking of probably less than 7,000 people out there to support, and there is a need of almost 56,750 based on the prevalence rate. So there is a huge gap when it comes to the supply side. And this is where you can see, for example, when it comes to the government sector, there's only half a dozen of hospitals that are literally available to support such patients. There's a high variability amongst the states, from 0.1 to 10 per 100,000 cases out there. And you can see the challenges on the supply side. So we need to appreciate and understand that, yes, there is this huge demand, but then there is a major gap between the demand and the supply. I think I'll probably stop here and hand it over to Joanne to talk about the international markets and the survey that we have carried out, and then we'll discuss it further.
Okay. I don't think my mic's working. Yeah? Okay. Right. I don't like being tied to the podium, so I'm going to get some steps in. Steps are very good for your mental health as well as your physical health, so I'm going to get some steps in while I do this, and hopefully it's not too distracting. So mental health coverage in international markets is interesting. We looked at a few international markets, particularly UK, USA, Brazil, South Africa, UAE, and they each had slightly different ways of approaching the issue of mental health, in law anyway. So USA has a separate mental health act. It's very clear about expecting parity between mental and physical coverage of benefits. In the UK and South Africa, there's no separate act. But there are, particularly in the UK, there is a set of directives that say that the NHS should give parity between physical and mental health. Now, that doesn't happen in reality for the same issues that it won't happen in reality here, and that's because the supply side is much, much more constrained. So if you're looking for a physical intervention, you might have a waiting list of a few weeks to a few months. Quite often, if you're looking for a mental health intervention, you could have a waiting list of well over a year for certain mental health interventions. So although in theory there's parity, in practice it rarely plays out like that. And then in Brazil there's no separate act, and in UAE they're in the process of getting a mental health law this year. So types of mental illnesses covered tend to be pretty uniform, so people tend to use the DSMV, Diagnostic and Statistical Manual of Diseases, of mental disorders, and typical ICD-10 codes. And then in South Africa, they have a slightly different system. And the plan benefits tend to be relatively uniform. So we're looking at inpatient, outpatient treatment. But the interesting thing in particular about mental health is that it's very, very hard for insurers to manage. And therefore, most insurers tend to default back to number of days limits on inpatient treatment, number of visits limits on outpatient treatment, and or some kind of monetary limit. because it's extremely hard to manage. So one of the things that's interesting here is thinking about how you do underwriting and risk assessment. So in most countries, it's based on the discretion of the underwriter, but there is no separate risk assessment for mental health. And when I get to the bits about the India survey, then I think that's important because one of the results that came out of that, for me, was slightly counterintuitive, which I'll speak to in a second. But the same key challenges arise, so lack of data, pricing difficulties, you can't allow risk selection, not enough doctors, so the supply side issue again. Risk mitigation strategies all tend to be fairly uniform, so again, we've got strict benefit limits. Sometimes you see things like limiting inpatient stays with, rather than just a benefit limit, with actually specialist units set up within insurers. And the UK went into this in a big way about 10 years ago when insurers realized that their psychiatric costs were getting to be a larger and larger proportion of their overall costs, and in some cases were well over 10 to 15% for the more generous policies of their overall costs. And they set up a lot of specialist case management around it. Now, as you can imagine, if somebody is in a psychiatric hospital, it is very, very, very difficult for an insurer to be able to move them on from that setting, because typically the benefit plans don't support other non-inpatient interventions. There's nowhere for that person to go. If that person doesn't have home support, then it's extremely difficult to set these things up. And therefore, even if you have some quite specialist case management around it, and a lot of insurers had psychiatrists on their staff managing these cases, it's difficult to know how in reality as an insurer you can limit your financial exposure at that point. If that person has major depression and is in a secure psychiatric unit and can't be released because they're not getting better, and often with things like depression, it takes many, many, many weeks of treatment for even basic drugs to start working, what can you really, in reality, do in that situation to limit your risk? And the answer is very little, no matter what you've got written in your policy terms and conditions. So there was a lot of specialist case management. There's a lot of co-pays and those kind of member co-insurance type issues. I'm going to move on in the interest of time and talk a little bit about the industry survey. So we sent out a survey to 9 insurers, well, more than 9. 9 responded in the India market. Primarily underwriters responded, although we had a few actuaries respond as well. And we asked a number of questions, and I'm just going to go through some of the answers to those questions and just give my comments on some of those answers. So there was a lot of concern about mental illness definition, people considering the definition in their new product filings, thinking about how they were going to set up a defined list of included or excluded mental illnesses. I don't know how you do that in reality. But a lot of people out there seem confident that they could do it. So I'm fascinated to see what comes onto the market, because I haven't seen anybody anywhere in the world manage to do this with much precision. We asked a bit about product design. We had quite a few people say there was some expected progress on product design, so indemnity cover up to a sublimit, standalone mental illness products. So I was fascinated by this one. I don't think I've ever seen one of these anywhere in the world. And yet, half of the people in our survey said, we expect to develop a standalone mental health product. Now, one of the issues with that is that mental health and physical health are very, very indivisible. So if you have a mental disorder, you have a very high probability of having a physical comorbidity, and if you have a physical disorder, you have a high probability of having a mental comorbidity. The other thing about it is if you have physical coverage in separate products with wellness benefits attached to those, your ability to engage that person in the wellness part of that benefit is going to be severely limited if they also have a mental comorbidity. And in some studies I've seen, you would be better off treating that mental comorbidity, and it will reduce the physical costs of illness, than you would be to leave it alone. So I think if you go down the route of thinking of them as totally separate things with separate products, I can't see how you would make that work in reality, and I'm not sure it makes much economic sense. but just something to think about. Treatment design options, so there was lots of willingness to provide coverage for different types of treatment options, so not just the sort of standard Western treatment, if you like, but a lot of other treatment options. I think that's fine. I think I would have a slight concern with some of those treatment options that what's to stop you funding a week in a spa for somebody who's mildly depressed? I'd quite like a week in a spa. If someone was going to pay for it, I'd be pretty happy. I've seen that happen in other countries. These things are very difficult to control. It's very difficult to be able to think about the definitions that you would put in place to allow people access to certain benefits. Risk mitigation, people were going down the route typically of pre-existing exclusions, deductible co-payments, annual benefit limits. I think that all makes sense. I'm not sure how you pick up some of those pre-existing things. And this sort of leads on nicely to underwriting process. So I was fascinated to find that the vast majority of people in our survey were looking at doing some kind of telehealth underwriting or interview for mental health screening. Now, if I have mild to moderate depression that I haven't yet admitted to myself, and you put me in front of a telehealth underwriting system, so maybe something that's like a standard depression questionnaire, and it spits out, hey, Joe, you're mildly depressed. I'm not going to be very happy about that. You're diagnosing me. So I'm not sure how you ask those questions. You can ask standard questions about, have you ever been admitted for psychiatric treatment? Have you ever been diagnosed? But given the prevalence of undiagnosed disorder, I'm not sure how that really helps you as an underwriter. So that's also something to think about quite carefully. I'd love to be able to see these questions that are filtering out these people with mental illnesses, because I couldn't get my head around how that was going to work. So there's lots of pricing challenges, as we've already talked about, lack of clarity on cover, changes in consumer behavior, initial low policyholder awareness. I think the biggest pricing challenge is going to be that supplier side issue, because we all know that the most important thing for your utilization rates is going to be access to the supply side. And that initially is going to be severely constrained, but that may change over time. Expected claims costs, so we had a very, very, very broad range of results to this. So we basically said, what do we think will be the increase in claims costs due to inclusion of mental illness? And we had answers ranging from less than 1% to over 10%. That's a pretty broad range. I would be on the low side of that initially, just because of the supplier-induced demand issue, but I could see it increasing quite significantly over time. I think it will have a much higher inflation rate than a standard physical-only product. Information about networks was very lacking, so most people didn't know what kind of facilities were out there. They didn't know what kind of mental health network they were going to be able to get. They didn't have any information on the mental health facilities in particular areas, so that's going to be a problem. And then that comorbid risk, I've already talked about the fact that it's basically intrinsically linked with physical disorder, and therefore you really need a strategy to manage both of those at the same time. They are not typically separate, divisible things. So I'm going to go through this very quickly because I'm aware of time. I'm trying not to do the thing that everybody else has done of run over time. So key considerations, we've talked about some of these already. Product design and definition, so clarity on definition, you're likely to get very significant variation in interpretation across different insurers. Pricing, we've talked about. Underwriting, I think, is going to be extremely difficult, particularly for a mental health only product. I don't really know how that would work. Claims processing management, so I would imagine you're going to get non-disclosure unless you write the magic questionnaire that can pick up lots of undiagnosed illness. You're going to have trained claims assessors, and then there's issues, I think, around data collection, and then typical knock-on issues around reserving if this does turn out to be a relatively big deal with a fairly high inflation rate. Some of the other considerations to think about, so rights of people with mental illness and the provision of advanced directives, which SAFTA referred to already. It means patients might have greater control on the preferred choice of care, and providers might have quite limited control on how they actually define that appropriate treatment. Typically, what I've seen in other markets is that you as an insurer have almost no control over that treatment pathway. So if you think you have very limited control over the surgical treatment pathway, wait till you get to mental health. You're going to have almost zero say in it. Insurance provisions, so not much clarity around what can be covered within the insurance cover. There might be some innovative products. I mean, I'd like to see more innovation around the wellness bit and whether or not you could integrate the mental and the physical benefits and actually come up with a strategy that manages health overall. I think potential there for much more comprehensive insurance products with outpatient cover. A lot of mental health will be on the outpatient side, so that's something to think about. We've talked about supply provision already. And just a point here on admissions. So, as I said earlier, some of these things, if you get very serious mental illnesses, these people can be in hospital for a really, really, really long time. A really long time. Months and months and months and months and months. And you've just got to think about how you're going to manage that a little bit. And then lastly, just a note to insurers, so keep an eye on what the Mental Health Review Board are doing, because some of those modifications of advanced directives are likely to have implications on the coverage that can be offered. So keep them close and keep an eye on it and see what's going on there. Okay. I think I did kind of okay.
Thank you. Any questions on this topic? You want? Mic, please. Mic here.
I was going to let the gentleman up the back go first. Just a personal point, which is one of the things that I make a point of saying here. You mentioned stigma with mental health, and it's an important point. And one reason why these sorts of things still cause a lot of problems in the community is that there is that stigma. And it's up to people such as myself to actually help to overcome that stigma, because I suffer from depression. You most probably don't recognise it because I'm able to be adequately medicated. I'm not the sort of person who should suffer from depression. I do. I'm okay with it. But when I first came down with it, I had to take months off work. And you're right, that's an incredible cost. Luckily, I was with a very good employer at that point of time. But as professionals, as people who are supposed to be rational about this, suffering from depression is as bad as breaking a leg or having some other physical trauma, which is obvious. The thing is, depression is not obvious to most people. So we have to, as a profession, actually reduce the stigma in the general population. And that will help all that we're doing there, and it will actually reduce the cost to society as a whole, even ignoring the cost of insurance and so forth. So that's basically what I'm here saying. Reduce the stigma, which means anybody who's suffering from mental illness should think very seriously about telling other people. So.
Thank you.
Hi, thanks both of you. Wonderful presentations, a lot of information. But if I walked in with 2 questions in my mind about mental illness, now I have 10. So good that you're making us consider about all the challenges that are there with respect to mental illness. But you've mentioned multiple times about that we do not have a control over what is the kind of payout that we would expect for such kind of illnesses and its treatment and how long it will go over. So as an insurer, I'm worried about how do we go about forming a framework around it? Now, obviously, we are having it here now, but maybe the UK, it's been developed. UK, US, they are developing a framework. Brazil, I saw, had a regulation since 1999. So they might have done already something. Can we just pick on those positives that they have done on? Do you have any insights on what they have done which we could pick up on and build a framework around rather than keeping so many open questions with us?
So,
Sorry if it was a difficult question.
So I mean, to be honest, I don't think anybody's doing it particularly well. I think that's part of the problem. So if you look at the responses that insurers have made in other parts of the world, they've been very rational responses from their perspective. They said, well, we'll only pay for a certain number of days, we'll only pay for a certain number of visits. There's nothing outcome-based about that. And therefore, what tends to happen is people, they have treatment for a period of time, they run out of coverage, they stop having that treatment, they're then in a cycle of being sick again and then requalifying for treatment and basically going in and out of the system. And I see that in many countries, and that happens in the UK, even with the National Health Service, because there's such limited capacity for beds. And in the spirit of sharing, as the gentleman there did, I don't have depression myself, but my mother has major depression on and off throughout her life and has spent many, many months in various NHS hospitals. And I can tell you, from a personal perspective, first of all, they're not places that you get better. They're places that you basically are held in a holding pattern until the drugs work. They're not there to give you comprehensive treatment. They're just not set up in that way. They're not anywhere that I would ever wish anybody to spend any time, quite frankly. And they release you as soon as they possibly can because they need that bed for somebody else. And therefore, 3 months later, you're back in that bed when you've risen up the critical list and somebody else has gone down the critical list slightly. So I don't think there's any easy answers to that. I don't think insurers have the answer to that, quite frankly. I think insurance is going to play a part in this, but we, from a financial perspective, the only way that we can really limit our risk at the moment is to put some very strict benefit limits around it. And we have to acknowledge that that is not going to solve the problem. But I don't have any great answers for how you can solve the problem, because one of the other issues you have, of course, is that the benefits to managing somebody's mental illness are typically going to accrue to their employer through less work-based absence, through all of those things. And that person's going to have a much happier, more fulfilled life. There's no benefit to you as an insurer for that person having a much happier, more fulfilled life, but there is a benefit to society. So I think to look at it as an insurance-only issue is only to look at one small part of the picture.
Yeah, I just want to add one more point to this. The fact that this has raised more questions, I think, in itself is the objective of this presentation. That there'll be more questions than answers at this stage because we are in the very early phases of understanding. I have it. Yeah. Sorry about that. No, what I was saying is that the fact that this has raised more questions than answers in itself meets the objective of this presentation. It was meant to raise questions because we are in an evolving process when it comes to mental health. Now, there have been certain quick solutions in certain markets that has worked implicitly. So, for example, trauma. Trauma is a big issue, particularly after an accident when a person enters into trauma, which leads to depression and mental issues, and it can go on. And some of the jurisdictions do have some insurance funds, social insurance funds, where you would support people who go through trauma or certain major mental illnesses that get really prolonged to be met by some form of insurance fund. But this is just one example of what some of the jurisdictions out there are doing. But as Joanne mentioned, there is no easy solution to this, and it will evolve with time.
I don't think any health insurer has got a policy. Okay, I think questions are over. Thanks for the good presentation by speakers. Let us give a good applause to the speakers.
A simple pentagram, that's all.